Well, welcome to week 8. It's amazing. You're going to turn around in 3 weeks. You're going to be doing a HESI and then doing the remediation, and then you're done with another quarter of nursing. And then it's on for most of you to capstone. So this is the time you need to hang on tight. A lot of stuff's going to be hit at you. Just keep it one foot in front of the other. Don't get frustrated. Don't scream. Don't yell. It's okay. You're going to get there. All right. You guys have done a great job so far. I've really not had to chase anybody about anything. So I congratulate you for being those students that really get your stuff done and really do work hard. So I appreciate it because I put a lot of time and effort in making sure you get what you need, but you take that information and you use it. So thank you, all of you. You're all going to make really good nurses, and I can see that in the future. Because if you can keep up with this semester and keep your assignments rolling in the way they should, without a constant reminder, you're all going to be great. So I look forward to maybe one of you taking care of me one day. So week 8, we're doing GI, GU. I did send you that worksheet with the answers. There's a lot of names of diagnoses, and to keep them straight, I made this matching sheet several years ago, and I found that the students really enjoyed it. So I made sure that I incorporated it into the online pediatric program. I think it is good, and it just is a quick explanation of what does that mean. Then you have to go in and look at the diagnoses and say, okay, so what does that mean for me as a nurse? What do I need to look for? What are signs and symptoms? How do I treat these things? Okay. So at least now you have a basic. These are the things you need to know. This week is full of assignments, and I did turn on your grades. So you can see how the subjective grades affected you. But I got to say, this class, people aren't missing homework. You all have it turned in. So your subjective grades have increased your grades, and that's amazing. So I know many other classes are fighting to get the assignments done, because these subjective grades are 20% of your final grade. So once you meet that 78 with quizzes, with exams and your HESI, then we add in 20%. 20% it will be a lot. And I've seen good students that have, 88 in a class end up failing because of not getting any homeworks in. So, this week is going to be hard. Now, the first big thing on this week is going to be your pediatric, the clinical assessment assignment. I did send you an extra form, and that extra form is, you have it in the modules, but it's a PDF. And some students don't know how to change it into a Word document. I mean, many of you do, but some of you don't. So I made sure you had the Word documented. Now, just type on it, save it, and send it back to me. You don't have to print it and do handwriting, okay? Actually, it's easier for me to read it typewritten than reading some people's handwriting. I know my handwriting is the pit, so I don't want you to have to do that. Now, when you're filling out the assessment portion, don't tell me within normal limits. Describe, what is the heart rate? Is it regular? Are there murmurs, etc.? The lungs, if it's not asthma, they're clear in all lobes, air entry good. If it's asthma, I'm wheezing, right? So make sure your assessment goes to the diagnosis that you are going to use. Now, if you don't know if your diagnosis would be an appropriate pediatric diagnosis, send me a message and say, hey, is rhabdomyosarcoma a good diagnosis? And I'll say, absolutely. Okay, so then that will, waylay any fears for you. So the first part, a 250-word APA, describe me the diagnosis briefly. Tell me what it is. Then you're going to do the assessment form, okay? And fill it in as well as you can. And the third part is a teaching tool. You can teach nurses. In fact, when I was on ground with pediatrics and the clinical instructor too, of course, I would teach nurses sometimes a diagnosis because we don't know everything about everything. So I had students teaching registered nurses some of these syndromes or some of these techniques that they didn't know about. So it could be to a nurse, could be to the child, or it could be to the parents, or it could be to all of them. And it could be a PowerPoint, and it could be 5 or 6 slides. You don't have to go nuts. You could do asthma, and you could teach me how to use a spacer, or you could show me how to prevent asthma, or you could tell me what treatment I should do or what to avoid, okay? Those sort of things. 5 slides is more than enough. Or make me a brochure about it, or just a picture board, describe it with pictures. Make sure there's a reference on your teaching, okay? So the last slide should be a reference page, a minimum of 2 references, please. Not just the book, give me another one, okay? If you are undecided about your assignment, did I do it good? Is the grade gonna be okay? Send it to me, send me a message, I'll review it. I will send it back and tell you what to correct. This is 6% of your grade. I want you to get the best grade possible. I will allow you in multiple back and forth. Tell me, did I do this okay? Did I do that okay? Or I will see plagiarism too high. Say, hey, use your words more. Get it down 30% or lower, which is quite a lot of plagiarism. But for you all, I think that's an appropriate amount that I can allow, okay? And when you turn it in, it immediately goes through the plagiar checker. So you'll be able to see it too, okay? Any questions about that part, the clinical assessment? Choose one, could be what you had, a next door neighbor had, your brother had, your uncle, it doesn't matter. Choose something that would interest you, and that makes it a little bit more fun. Then you have your NCLEX questions due, the diabetes, which I will check on, thanks for telling me, and the pediatric assessment assignment dues by Sunday. Apparently there was some confusion on diabetes and the assessment assignment, so after class, I'm gonna look at another area in my computer that I have to set it up on, just to make sure it's set up right. So I will do that for you. So today, we're gonna go over GIGU, and then we're going to do our Kahoots. And again, I've redone a lot of the PowerPoint and I've redone a lot of the Kahoots to make sure you're getting those concepts, giving you questions that you need to understand how to use the question, not only with the answer you're getting, but what did it mean, okay? So anybody here who's off screen, do you want to come on screen and say hello to me? Unless you're driving. Somebody's already said they were. But Clara, there you are, Consuelo. Jose, where'd you go?
I'm sorry, I'm trying to pack right now and also listen.
Okay. I know about Marjorie and Stacy. Jose, are you there? Maybe, maybe not. Okay, perfect. Thank you so much. All right, so let's go ahead. Let's go to our PowerPoint. You know, I put more pictures on it because, you know, I like pictures. And I think pictures tell you a lot more than I can tell you with words. So there's some more in here than I mean, every semester I add a little bit more. So GIGU, you know, we're talking about gastrointestinal and genitourinary. So urinary, let's go right into that and let's discuss that and what are the disorders and defects on the GU system as in specific to pediatrics? Well, the first thing we know, urinary tract infections, and they are big in the pediatric world. Why? Well, there's short little tubes. We know they don't wipe themselves well. We know that it could be bubble baths in girls, and it could just go from, you know, the little bit of dirty bottom goes right up into the urinary tract, and then we get these infections. Another thing is uncircumcised boys. Now, I have found in my career that many mothers do not like to pull back the foreskin and clean it They think it's going to hurt them. And honestly, if we leave that foreskin tight, number one, it can get so tight, we call that a phimosis, or that narrowing of that foreskin, then you can't pull it down. But if we can pull it down from birth constantly, all that white cheese-like substance called schmegma, it's like a big petri dish, and it just grows bacteria. So you can see it's going to go right down the urethra, right up into the bladder, and cause urinary tract infections. So those are the reasons why we have these urinary tract infections. You know, little girls sitting in diapers, the stool goes right up in there because there's nothing to hold it back. And then, of course, the uncircumcised boys. So when do we know a kid has a urinary tract infection? Well, if it's an infant, it's harder to tell. You know, probably a fever or maybe foul smelling urine might be the only thing that we see. In the older child who's already toilet trained and they start having accidents, that could show us. Or we see that redness, they're itching, that frequency, they're holding it, or they're telling you it hurts when they pee. Those things that need to be evaluated. So the best thing to do with children is that preventative of it, right? So number one, teaching our parents, what does a child with a UTI look like? Tell them about that simple front to back wiping. There are some people who don't understand that, you know, that you shouldn't go from the back to the front, and that can cause that E. coli to go up into their bladders. So making sure that's done. And then, of course, regular cleaning, pulling back the foreskin, cleaning those things. And with adolescents, urinary tract infections could be due to intercourse. So we should tell them if they're going to be sexually active to urinate right after intercourse, because that can decrease the amount of urinary tract infections. So how do we treat it once we figure out maybe that's what it is? Well, we need a urine culture and sensitivity. And we've learned that a catheterized specimen on the smaller children is the best way to go. And again, I'm going to emphasize, if you've got a little baby like the size of this one in this picture, and we just do a bag urine, we're going to get a lot of bacteria that was on the skin. It's not going to be as accurate as we want. And we don't want to play around with an infection on small children. They don't got an immune system at all. So if we do a catheterization and it's clean, we get it in, get the urine, we're going to get a good culture, and we'll know what antibiotic to put this child on. So we do it one time. We don't have to keep doing it over and over again, because if it's the wrong antibiotic, it's not going to work. What's going to happen? The child's going to come back. We're going to put them on another antibiotic. And what's happening in the meantime? That child's with that infection in the bladder going up the ureters into the kidneys, and now we have a pyelonephritis, which we don't want to do. Now, how do we do that on the little tiny little 1 pound premature infants? You know, we still need to do, if they're having fevers or signs of sepsis, we need to do a urinary culture. Well, we do that by a suprapubic aspiration. So we clean up right over the symphysis pubis with a good alcohol or cleaning solution, whichever it is of the day, betadine, or whatever the hospital policy is. And the physician does this, you know, with sterile technique, using sterile gloves, taking a syringe, sticking a needle down into right above the symphysis pubis. That's where the bladder is. Pull out, you only need a half ml. That's all you need. And we've got a really good culture, okay? Now, this is uncomfortable, yes, but a lot of times these premature babies at that size are on some sort of sedation, you know, keep them calm because they're still intubated, et cetera. So, you know, they do look out for pain control. Sometimes we have to go and take it out of the kidneys, which means a tap right into the kidneys. Sometimes we'll take a catheter in and we'll wash out what's in the bladder and pull it out, and we'll test all that, you know, whether sludge or whatever's in there. We can do ultrasounds. As child get older, we do something called a VCUG, or a voiding cystourethropography. And that is an examination we do for that child with chronic urinary tract infections, we can look to see if there's any structural issues going on. And then as you get older, IVP, looking for stones, and then of course you can do scans. So let's say we've got to go in and do that renal biopsy because there's something in that kidney. We can't get a good culture. The cultures are not showing what's there. We got to do this percutaneous type of right through the skin into the kidney to do an examination. Many of the nursing responsibilities post-op sound like a cardiac catheterization, okay? Very similar. So number one, we'll prepare them. If it's an older child, we'll let them know what's going on. We might even sedate an older child for this because it is uncomfortable and it's scary. And you are sticking a needle down in through the back. So it can hurt, right? Using all the numbing medicines that we can. And so we go in there and we get our specimen. And now we have a puncture from the kidney, that is now sort of open to the outside. So we are going to put pressure there. Now, a pressure dressing, pressure sandbag, something there, and we're going to monitor for any leakage, and we're going to look for abdominal pain because that kidney could leak urine into the belly, and it could really cause discomfort into the peritoneum. So abdominal pain, tenderness, and then the intake and output. Are they still putting out good urine, okay? I mean, the smaller kids, they said you might have to do a surgical incision just to find the kidney, but a lot of times they'll do this under ultrasound. These children will be on bed rest for 24 hours afterwards. So monitor their bellies, monitor urine and output, and also checking that dressing regularly. So I did mention sometimes we have an obstructive problem going on, and it could be anywhere. It could be in the ureters. It could be anywhere in the ureters. It could be at the junction of the vesicle, which is the bladder, in the ureter. So it's a vesical uteral obstruction that can go on. It could be one side, both sides. It could be more than one occlusion. It could be complete, which means there's no flow, or partial. So just basically remember the bladder is called the vesicle, okay? And then, the ureters, and of course, nephrosis means kidney. Now there is a syndrome called nephrotic syndrome. Has nothing to do with kidney failure. I'm going to tell you again, nothing to do with kidney failure. You're urinating. So what you know about acute renal failure, forget it. It is not nephrotic syndromes. What happens with nephrotic syndromes? The kidneys say, hey, protein, I don't like you. I'm getting rid of you. So in your urine, you're spewing protein like crazy. Okay, massive protein loss. So what happens is this. Intravascularly, all the protein is gone. So now we've got to be careful with medication administration. There's no albumin, there's no protein. So there's all free-flowing drug in there. So very careful with that. Also, because of the intracellular and extracellular, it'll pull the fluid out into the extracellular, so there's swelling eyes. You're going to see puffiness all over the place because of the protein that's being lost. So how do we manage this? Well, we usually will just give a steroid to stop this from going on, but these children for life, this is a chronic condition. It's not a cure for it. You don't replace the kidney. It doesn't do anything because, again, it's nothing to do with kidney failure. The kidneys work. They just don't like protein. But because of all this swelling, this edema, we're going to be on fluid restrictions. We're going to be on salt restrictions. And, we have to be careful with activity with these children, okay? Because of fluid restrictions, right? And this is something that intake, output, and daily weights they're so important. Priority care, your daily weights, I&O. So we need to prevent that protein from going out. We need to reduce the fluid retention, and we need to minimize infection. So Again, our priority, I and O in daily weights. And as I said, usually we'll just give corticosteroids to these children and it'll be okay. Now, problem is family and family involvement. You know, we have to let the other kids in the family, the siblings and the parents know how important it is for these children not to drink too much. I mean, abuela cannot give an extra cup of juice. You know, grandmas can't do that. You know, it'll hurt the child. It's not something that's a reward on this kid. And I know me as a grandma, I would do something like that if I didn't know better. Now, we've talked about rheumatic fever and strep throat, right? Well, here's another one. Acute glomerulonephritis can be caused due to a strep infection. And it could happen up to 3 days after you have that strep infection. So what happens? Well, you stop urinating, oliguria. Again, you're not urinating, what's going to happen? You're going to swell. And if you're swelling, what happens? Your blood pressure goes up, hypertension, and you'll see hematuria and proteinuria. So what do we do for these children? Well, usually these kids, as I said, it's the streptococcal infection. So we need to treat the strep infection. And most of the time, these children will resolve it. But some of them get to the point of chronic, depending how quickly it was caught and how much damage was done. So, all right, you're swelling, you're not urinating. What is the nursing care? How do we manage these kids? Sounds sort of like nephrotic syndrome here. Daily weights, INO, and these children, we're going to measure their abdominal girth to see if maybe they're swelling within their abdomens. Again, low sodium, fluid restrictions, and we'll be worried about any infections on these children. Wilms tumor. Well, Wilms tumor is that adrenal tumor. We sort of talked about it when we talked about tumors, but this is your 3 to 5-year-old boys, African American children, and it's something, a nephroblastoma. It comes off the kidney, off the adrenals, and it becomes really, really big. I've seen one in my lifetime. And it was this little guy from Haiti who came over after the Haitian earthquake. And they only spoke French and all the records were French. So I did an assessment and I found a softball size tumor in the left lower quadrant. I had never seen Wilms tumor. I didn't even really know about it. But all of a sudden my head went, huh, this is a Wilms tumor. And why I knew that, I have no clue. I mean, it must one of those little things they make us do, you know, all of that extra, like do all of these modules, you know, to keep up your nursing license thing, one of those, and I found it. So I immediately told everybody, don't touch the abdomen. I'm telling you, it's this big, it's there. And what did this kid do? It went through chemo, radiation, and then they removed it. We do not do any sort of biopsy on this. That would be like touching it. And little pieces of that tumor could go off within the peritoneum and it would be a metastasis. So there, when we see the tumor, we know what it is. We leave it alone until we go in and remove the whole thing in surgery. And our job is don't touch that abdomen. And then post-op, we're going to watch urinary output. And of course, for the bowels to be moving. With abdominal surgery, you always watch that. Now, children can go into renal failure. It's due to many different things. It could be an acute phase that occurs, or it could be chronic. Now, acute stage, you know what the #1 reason for acute stage renal failure? Dehydration. That's how serious dehydration in children can be. And chronic renal failure could be an anomaly, or it could be some genetic or something that goes on. So what happens with acute renal failure? Now, I've seen actually ibuprofen cause an acute renal failure in a patient. They were taking it because they were having pain and all of a sudden they stopped urinating. They went to the hospital. They were just about to do dialysis, and 2 to 3 days later, all of a sudden they were urinating and they didn't have to do anything, and the kid was fine. And then they realized it was the ibuprofen that had caused it. So just something like that can cause things like that. So acute renal failure, again, that's most common is severe dehydration, but finding the cause, what caused it, and it can turn around. Now, chronic renal failure is something where they say more than 50% of the kidney's capacity is destroyed. It's not working anymore. The kidneys aren't working. So, and it deteriorates slowly, slowly, slowly. Why does it happen? Why do we get chronic renal failure? Well, it could be that urinary tract malformation, that vesicoureteral reflux, urine going up and down from the vesicle, the bladder, up the ureters, up into the kidneys, damaging it, causing chronic infections. Could be hereditary. Where the hospital where I worked, was doing clinicals, doing the clinical rotations for some students. And I was up on that floor, and I never worked that floor per se. And I noticed there was a lot of kids in the dialysis unit. I'm like, I didn't realize there was so many. And what they told me that there are some cultures that marry within their families, I guess to keep the money or something within their families. And that closeness of children ended up having children with, problems like renal failure. It was one of the things. So I was very, okay. We know that the infections can cause it, but of course, anaphylactoid purpura, have anaphylaxis, it can kill kidneys, or lupus. Lupus can kill any organ, but of course it can kill kidneys too. So how do we manage chronic renal failure? Well, we want to try to make the kidneys work as well as they can. Fluid electrolytes we know is important. They always have a very, very low hemoglobin hematocrit. So we're going to give them the erythropoietin, which is an injection sub-Q that helps the body produce red blood cells. If we can decrease the amount of blood transfusions on this child, it's the best for the child. And then, of course, trying to get this kid to be as normal as they can. And many of them have to come in 2, 3, 4 times a week, 3, 4, 6 hours, having dialysis. So their lives are really a slave to the machine. Now, there's other methods that we can do dialysis, and we cannot do hemodialysis on an infant. That swirling of blood in and out, cleaning the, debris out of it is too much of a swirl, and it can take the vessels in the brain and burst them. So they're going to have hemorrhages in the brain. So you can't do hemodialysis. So what do? We do peritoneal dialysis. In fact, this has become more of a thing in adults in the recent years. They're using it more because why? They can stay at home. You can do it at night when they sleep. And it is a great concept to use, keeping the kids home, not taking them to dialysis 2, 3 times a week is a good thing. Now, what do? Well, this is a little example of the catheter. Somewhere it's put into the peritoneum. The main thing is to keep this procedure sterile. Your only way of getting urine off this infant and the debris that needs to be cleared out is through your peritoneum. And if we get an infection, peritonitis, guess what? You don't have a kidney anymore. And if you don't have a kidney, you can't do hemodialysis. Outcomes are not good, right? So the big thing about this is they take warmed fluid, and it's called a diastolate. It's, whatever's combination of electrolytes and sugar or whatever that the nephrologist wants you to use. And we take it, warm it. We put a certain amount into the abdomen, and we call that a still. Let it sit there. Maybe it's 20 minutes, maybe it's 30 minutes. And then it's all on a machine. And then we drain it for 10, 20 minutes into a Foley catheter. So we instill it, it stills, and it drains. It's a cycle. We might do 8 or 10 cycles every night. Now, how do we know how much urine output? Well, we know how much went in that infant by all the cycles. So if we did 100 mLs, we did 10 cycles, there's 1,000 mLs, right? So if we look at that Foley catheter of all that drain, the difference between 1,000 and what's in there is urinary output. That easy. Now, the biggest thing, as I said, worrying about infection, if that color of that fluid that comes out changes, or you're seeing particles, debris, there's something wrong. Notify that healthcare provider immediately. That child's going to need antibiotics. We have to protect that abdomen, okay? I've actually seen a kid who had dialysis, peritoneal dialysis, and he finally at age 2 got his kidney, but that mother never had an infection. That kid, dry skin, she had him lubed up and he was always in the greatest of mood. And that catheter, that dressing that she would put on is as good as a dressing I'd put on because I'm a little OCD. It has to be neat and no kinks and done right and hooked up this way. And let me tell you, that mother was amazing. So what best describes acute glomerulonephritis? What do we know about it now?
Streptococcal infection causes it.
Absolutely. So we know there's rheumatic fever and glomerulonephritis are the two things caused by strep infections. We never knew that before, did we? It's crazy to think that a strep infection can cause that much damage. Now, the GI system has quite a bit in it, okay? So hold on to GI. Well, let's start with nutrition. Well, what does a GI system do? They absorb all your nutrients, right? So there are things, cystic fibrosis, we know, and there's other types of things that can cause a child not to grow. And it all depends on your intestinal tract and what nutrients we need to put there, but there can be loss of vitamins, minerals, etc. Well, here's one of them that causes this problem called celiac disease. And celiac disease is where the villi in the small intestines gets really upset by different types of foods, okay? And the tract does not absorb fat at all. So this child's going to be a loss of all the fat vitamins, right? So when the stool comes out, because it doesn't absorb the fat and the fat comes out, you're going to see a pale, thick, like stinky stool on this, okay? So how do we take care of this child? Well, we put them on a low gluten diet. So what sort of flours are we not going to allow this child to have? Barley, wheat, rye, right? So this kid can't have like anything breaded, no bread, no sandwiches, no macaroni and cheese, no chicken nuggets. So you got to be careful. Today, though, we're so lucky that there are a lot of alternate products that can be used instead. I mean, 20 years ago, they didn't have it, but now they are doing it. Food allergies. Well, children do get food allergies. And that is why when a child's 6 months old and we start giving foods to these children, we go slow. We go real slow. I mean, 4 to 6 days in between because they can have allergies to a certain thing. And it could be a rash, this evident, or it could be just underneath the chin, in the pit, the arms, and underneath the knees. But it's basically showing us there's a problem with that food. So the other one is, we'll see almost immediately, is a lactose intolerant, some of these infants, and they'll just be vomiting and diarrheaing. So what are some of the problems with the GI system? Well, remember, if we are constantly burping and spitting up all the time, we are going to lose nutrition. So what happens when you don't get all your nutrition? Well, we're not going to grow the way that we should, right? We know cognitively there could be delayed depending on how much. And these children, you might see things like vomiting, diarrhea, constipation could be some of these causes. We also know that children can have problems with eating. I mean, if we look at this one syndrome called DeGeorge syndrome, one of the things is they're called dysphagia, or they have a hard time eating. They just don't get it in their mouth. They have little tiny little mouths, a little tiny little bottom jaw, and they have to really be taught how to eat so they're not swallowing properly. So there are many things that can cause this. Now, dehydration is when the output's more than the input, and it could be due to many, many different reasons. Well, if you look at this child here, they're cute, right? But look how pale those hands, the feet, and the lips are. This child's dehydrated. I can tell just by looking. You could see that pale, underperfused, probably dry diapers. Heart rate's going to be elevated. Blood pressure is going to be low. You know, why did it happen? Well, it could be vomiting, could be diarrhea on these children, or it could have sweat a lot. You know, parents overdress the kids, sweat a lot, and children get into dehydration really quick, really quick. I mean, when we look at the symptoms, I mean, I think these two pictures are amazing. Look at that fontanelle. This kid in the upper picture is just sitting there at rest. Fontanelle is sunk way down. But besides that, look at the color of the ears and the nose. That kid looks almost light yellow. That is a dehydrated kid. A kid should have a flat fontanelle at rest, okay? So sunken fontanelle, you're going to see heart rate up, blood pressure low, prolonged capillary refill. It could be 5, 6, 7 seconds. And of course, the big thing that we forget, kid is crying and no tears are coming out. It's like, oh, we're definitely dehydrated. So how do we treat dehydration when suspected? Well, number one, what was it due to? Was it vomiting, diarrhea? How severe is it? And most of the time, kids, if they're vomiting and they look this way, they're going to get IV. If they're not quite that bad yet, you know, and they're still a little pink, heart rate's not too crazy, we might start some PO fluids on them, which we know is an electrolyte solution. But we definitely need a basic metabolic profile. That's your electrolytes. We can see in the electrolytes, oh, this kid looks dehydrated. And remember, when we're giving fluid via IV, I mean, both of these kids need IV fluids. They both need a bolus of fluids now. That the whole body system needs to be perfused with blood. And we know when you're dehydrated, it sinks back. So not everything gets your blood flowing. So remember, no potassium in an IV until a child voids for you. Okay? That's very important. And we never, ever give dextrose as a bolus fluid, only normal saline. Ringer sometimes, but mostly normal saline. And if they're vomiting, of course, we're going to give them an antiemetic. There's no miracle drug for diarrhea. You know, they'll just give you some lactobacillus and tell you to increase the bulk in your diet to try to stop, and of course, bland foods. So measuring intake and output. We can measure everything on a kid, you know, urine, stools. We can, if they're sweating a lot, we can guesstimate, or if the doctor wants something more than that, we can measure, put the kid on, let's say a Chucks or a big diaper, and we could weigh that and look at that. Remember, the difference between a dry diaper and a wet diaper is the amount of urine output on a child. So if a diaper weighs 30 and the wet diaper you took off weighed 60, urine output was 30, okay? We can also look at the vital signs, right? Heart rate up. And then after we rehydrate, we can see that heart rate come down. I've given IV push fluids on children where their heart rates, you know, started at 140, a 2-year-old, which shouldn't be that high. Give IV push stuff. I watched that heart rate go down to 120 after 60 or 90 mLs of fluid. So you can watch this really quickly. Of course, mucous membrane, skin turgor. I mean, if you've got pitch, you know, tenting of your skin, you know there's a problem. Body weight. If we're gaining fluids, we know we're getting, you know, gaining weight, we're getting fluids. Fontanelle is a great thing. I mean, I wish older kids had fontanelles because you can really measure fluid balance by that. Diarrhea. There's all sorts of diarrheas in children, and it could be due to many different things. So, as I said, how do we treat diarrhea? Well, usually we give oral hydration. Why do we have to give an IV? They're not vomiting, right? So we give oral rehydration and we start a diet on them. You know, it could be just start with crackers, rice. You know, it used to be years ago, we called it the brat diet, but they don't say that anymore. Feed a kid what they want, but don't give a lot of grease or spice in it, you know, and let the kid eat. Because if we just gave fluids, how is the diarrhea going to get solid and stop, right? Constipation. You know, one of the things about constipation, usually it's due to some sort of problem, psychosocial thing going on. Children, the one thing they can control is their stool. I've seen kids hold their stool to 7 to 10 days. And it could be due to an emotional response. We moved houses, we changed schools, the dog died, mommy and daddy split up. It could be so many things that kids don't express with words, but they can express it by holding their stool because they want attention. So number one, of course, you always rule out if there is some sort of source for it, but many times it could be due to what's happening to the child's life. Now, a kid who's born, newborn children should stool, and it should look like this thick, like rubbery looking green black stuff called meconium. If we're not seeing this within the first day and a half, something's going on. It could be due to an obstruction in the intestines, like atresia means really closed, or stenosis, a real narrowing, or it could be due to Hirschsprung's disease. We're going to go into that. But look at that, hypothyroidism or cystic fibrosis. So we would be doing thyroid hormones, checking them, and we're going to be checking a sweat test for CF, okay? So sometimes when we have infants, you know that breastfed babies usually have a lot of loose stools. That's just normal. They just do. Bottle fed, formula fed infants tend to have a more solid stool. And the problem with that is sometimes it gets so hard they can't pass it. So a lot of times they'll just add some more water, or the doctor will say, give them a little prune juice or apple juice or something in between. But all physicians are different, but they'll do something to try to help you loosen it up. I mean, the last thing we want to do in constipation on an infant is give enemas all the time because they'll get used to it. So we try other things to help them. Now you're saying peptic ulcer disease in children. Well, children are little worrywarts. They really are. And they do get stress and they do get ulcers. So again, what's the treatment? Well, how do you treat an adult? Number one is diet, maybe adding some Pepcid, or we can go on all the medicines if we need to try to decrease it. I've really never seen a child need a gastrectomy due to an ulcer or a partial gastrectomy or for the management of an ulcer. If we can have that kid calm down, put them on a good diet and medicines, usually they'll be okay. Hepatic disorders. I mean, children can have hepatitis due to many different things. And, you know, these kids, we know that they're going to be the yellow color and the sclera and all of that. But treating this child as a nurse, what do we need to know? Well, these children need a high protein carbohydrate diet. Now, because the liver digests what? The bile digests fat, right? So we have to be really careful with the amount of fat that we give these children, but high protein and high carbohydrates. Now, I mentioned Hirschsprung's, one of those things which would cause no stool or very little stool in the first day, day and a half. Now, what it is the part of the bowel close to the rectum has no nerves in it, or it's called an aganglionic megacolon. There's no nerves, which means no nerves, there's no movement, right? If no nerves, you can't do the peristalsis. And part of that intestines gets bigger and keeps filling up with the debris from the GI tract. Because even if you don't eat, there's still, normal gastric juices and, mucus that is in the GI tract. Now, if you look at the bottom of this picture and see where that rectum pointing is, it's tiny, it's thin. So sometimes you might see a little like ribbon stool, which you would put like if you were icing a cake and you one of those little thing and squirt it out, and you want to make pictures with that tiny little ribbon, that's what you might see in it. So when we see no stool, we do an x-ray, we find out that it's not working, they'll do a biopsy, and what they have to do most of the time is a colostomy on these children. They remove that piece of stool, that bowel, and then they wait till the kid's a little older, and then they'll reconnect it. Usually they're mostly reconnected after they have the colostomy. Now, appendicitis. I mean, appendicitis, adult, child, is there any difference? Yeah, no. So acute peritonitis can be caused by a ruptured appendix, right? It's the same, right? Lower quadrant pain. You'll see kids walking into the doctor or to the ER, bent over, holding their right lower abdomen, right by their groin. And you're like, oh, I know what this kid is. And you're going to see them, they're hurting. Once they stop hurting, it's probably apparent that this now child has an ruptured appendix. So how do we treat this child postoperatively on a ruptured with peritonitis? Well, itis is an infection, okay? That bowel is angry of all spewing of all this GI contents went into that peritoneum, and the bowel is angry. So nothing to eat or drink, NPO. But we need to keep that bowel completely empty because they don't like that GI gastric juices going in there. So an NG tube to keep that stomach from dripping all that gastric juices into the bowel. We're going to be given antibiotics. Number one, IV fluids to keep them hydrated. We're going to be monitoring lab values, and the kid just had surgery, so pain control. But the one thing we forget is this peritoneum had, all of this contaminant spewed into the peritoneum, and it's dirty. So we need to be checking that wound, because who knows where they put that, when they did the surgery, if that wound, the stitches don't pop open. And it could, because that peritoneum full of all of these debris, it's not a good attachment. So you have to be careful. Again, you're going to postoperatively treat them like any post-op, good pulmonary care, coughing, deep breathing, instead of spirometry. Get them out of bed, ambulate these children, but of course, make sure they're medicated before you try to do that, because it hurts. Now, here is a diagnosis specific to your pediatric population. It's called intussusception. It's literally, you have the intestines and they telescope into each other and they hold. And it causes sudden, intense pain in children. 3 years, 3 months, it's in that area. Actually, the youngest I ever saw was 5 months. Usually it's that 2 to 3 year old kid that you see it, and it hurts. So what we need to do is do an ultrasound and find it. And once we find it, many of these children will, by themselves, it'll just open by themselves. And it will just come in and out, and we'll tell them, increase the fiber of the diet, keep the bowel moving, and they should be okay. Sometimes it gets stuck. And with every attempt we've done, it won't unhinge itself. Those children, very rare, will need surgery. I think one I saw in all of my career that needed to go to surgery and have that piece of intestines removed. Meckel diverticulum, it's in the end of a small bowel. It is a piece of tissue that sticks out with a big blood vessel in it that rips and it spews blood in your GI tract, but you don't feel it really. There might be a little bit of tenderness in your belly, but it's called painless rectal bleeding. And sometimes this diverticuli, or this little piece of tissue that sticks out, can obstruct. And then, of course, then it would be a small bowel obstruction. But the way we treat this painless rectal bleeding or this obstruction due to this piece of tissue is usually we'll go do surgery and get rid of it and get it out. And the outcomes are really good. IBS, inflammatory bowel disease, whether it's ulcerative or Crohn's, IBS, it's mouth to anus, okay? Colitis is just pieces of it that causes some irritation. And we know that the biggest way we treat this is with diet and good nutrition, because these children tend to be thinner. So give them good nutritional support. Many times steroids are required, and sometimes they have to go into some sort of, thing like your Humaras and your Enbrels and, your MABs, one of those biologics. And they can help prevent them from having outbreaks. At times they do need surgery, but the big thing is nutrition.
Professor,
Yes.
I saw that it says IBD and IBS. In the
IBS.
exam, we will have IBD or IBS.
IBD.
IBD.
But it's the
Okay.
same thing. It's the same thing.
Yeah.
Same thing.
Just to make sure.
No, I understand. When you have inflammatory bowel disease, it's an overall mouth to anus. Ulcerative colitis or Crohn's are sections of it that are segments that are going to be inflamed. Thank you, Raul. So, short bowel syndrome. Let me give you a little synopsis. Had a little girl, 6 months old, 8 months old, just had cardiac surgery, prolonged recovery, was on a ventilator, but they decided to give her food because nutrition was important through a little ND tube from the nasal down to the duodenum. So just a little bit of food. Well, we were measuring abdominal girth and we saw it blow up. So we knew something happened. Well, we had to take this kid to surgery and open it up, and she had a bowel that had died. It's called necrotizing enterocolitis, or NEC. It's the bowel just couldn't tolerate the foods, maybe due to a hypoxic episode. We don't really know. Not all children get it, but we see it a lot in premature infants. So what we found was 52 centimeters of dead bowel that we had to remove on this child. Small intestines. So you know what the small intestines does? It's all of your absorption of all your minerals. So they had to take it out. Now, they connected it back up, no colostomy, but we had to remove it. So there's not a lot of room for absorption of the minerals and the vitamins and nutrition. That is short bowel syndrome, when you don't have enough bowel to get what you need. So many of these children, it's nutrition. And if you see this little boy, he has a Broviac. He's going to get Hyperal and lipids at night, every night for nutrition. And then during the day, to ensure he's getting proper nutrition, they'll give him tube feedings, because nutrition is number one, absolutely number one. Another thing that can happen that causes short bowel syndrome is something called gastroschisis. Now, sometimes body parts are born on the outside and they don't close up inside the abdomen. There's two of them. There's when the stomach doesn't go in, and that's called gastroschisis. And then sometimes the urinary bladder is born on the outside. And, this is two different things where they got to get it back inside. And they do. So we just protect that area, keep it as sterile as we can. And eventually they get those organs put back inside, and it closes it up. I mean, the body still works. They're all connected. They were just born on the outside, okay? Hernias. I mean, you see that little hernia on that little belly button and you push it in and out and it's soft and it's cute, right? Well, what happens if you touch it and they're tender and it's hard? That would be an incarcerated or strangulated hernia, and it's needed surgery now because the bowel is going to die, okay? It could be belly button, you see a lot. The umbilical hernias, so common in the infant. In the older people, you'll see the inguinal hernia because they've coughed a lot, and then the inguinal hernia tends to pop open. And then the one that's uncommon but happens in the newborn child is called a diaphragmatic hernia. Can you imagine the diaphragm holds down the intestines, right? So it keeps the lungs and the intestines apart from each other. Can you imagine the whole left side? Usually is what happens if the diaphragm is open. So the intestines come up into where the lung should be, and it pushes the lung over. So the left lung is non-existent and will never be existent. And that right lung is now getting squished by those intestines. Can you imagine trying to oxygenate that child at birth? Let me tell you, it's probably the sickest kid you'll ever see. They end up usually on ECMO, which is like the heart-lung machine. And it's the machine that provides oxygen to the blood. So it gives a chance for the surgeon to have the child more stable, go in, push it down, put a mesh, and allow that right lung to work. But for life, they're going to have one lung. Outcomes are a lot better than ever with that today. Malrotation and volvulus, you can see these at any time. Usually it's your younger children, and you're going to see some pain in it. And malrotation is when the intestines wrap around an artery, and you're going to see it. The artery can't supply blood to the intestines, and it's going to cause pain and death and necrosis. The volvulus is when they make a knot on themselves. So then we can't get blood flow down. And sometimes it's loose and then it tightens up as they get bigger. So malrotation, volvulus are hard to diagnose, really hard to diagnose. But again, an ultrasound can help diagnose these. And then surgery is the issue. Now, there are some infants, and you know, I never saw one, called an imperforated anus. They don't have an anus. Why do you think you take a rectal temperature when an infant is born? Well, they say to get an accurate temperature, right? Oh, they're making sure the child has an anus. Because if you don't have an anus, where's all of the GI tract juices going to go? It's a surgical emergency. So that this child is going to have a colostomy for life, because they're not going to be able to move their bowels anyway, because there's no opening. And how are you going to make a sphincter work? You just don't. So this child will have a colostomy. There's all different sort of fistulas. I've seen where the vagina has stool coming through it. I've seen the anus have urine go through it, you know, and it's just these little openings that again will have to be repaired at some time, you know, because we don't want, you know, the stool going into the urine, right? Or the urine into the stool, that opening, again, infection. Now vomiting, right? Most common thing that you're going to see with your young children. So vomiting depends on what it looks like. So there's vomiting where they just dribble and they just vomit. And it can be due to the type of formula, or it could be due to a, you know, a problem where gastroenteritis, where, you know, their stomach is upset. So if we are having a child who is vomiting, you know, we have to stop the vomiting. So most of these children, you're going to get, again, that electrolytes, that basic metabolic profile. That's very important. But start an IV, give a saline bolus, again, not starting any potassium till they urinate, and then not giving a bolus with dextrose. Once the bolus is done of saline, then you start the IV with dextrose, because many of these kids don't have enough sugar on them with all the vomiting. I mean, what sort of nutrition has they got? They can't. And of course, don't try to feed them because they're going to feed what happen. They're going to vomit. So rest them. And of course, we're going to give an antiemetic to them. Now, children love to eat everything, don't they? They see it on the floor. They see a bottle. They're going to get into it. I'm telling you, the most common thing I see is them getting into their vitamins and eating the whole bottle because they're good, or getting into the Tylenol, the chewable Tylenols, because they taste good. Now, the most dangerous, of course, is your Tylenol, because then you worry about liver damage. So what do we need to know and what do we need to teach our parents? Well, you know, there are things that we should have available. And one is the poison control number should be somewhere next to a phone or in your phone so that something happens, you can call right away and get treatment. These children, you know, they say in infants and children that are eating these things, most of them, they don't want you to vomit because they don't want you to aspirate. And the aspiration could be the worst, okay? And then the other thing that they ingest is they like to go up to the windowsills and bite on them. You know, they're teething because it tastes good. Well, if you're in an older building, let's say you live in like New York City, and there are these older apartment buildings and they have lead-based paint, guess what? They're going to get lead poisoning from chewing on these windowsills because they're teething. I mean, it's what kids do, everything in their mouth, right? Explore the world with their mouth. These children will need chelation therapy. So I've seen many kids come in, I've seen them eat their vitamins, they're okay, unless there's iron in them. And usually vitamins, we don't have iron, we just have regular vitamins. But the Tylenol would be the worst one. And I think the worst one I saw was they ate some poison that was on a mouse trap. They put it in their mouth. The problem with that, it can cause bleeding, like bleeding. So this child had to be admitted ICU and monitor all their bleeding levels. So, you know, children, everything in their mouth, again, teaching parents just to put it away. Okay, another thing is reflux that children can have. Now, we know that there's that spitting, like I said, right? Spitting up things. But sometimes, you know, it becomes more and more. So they're going to say, okay, your child has GERD. You have gastroesophageal reflux disease. So these children, again, constantly losing nutrition, treat them with the normal things for vomiting, as in the Pepsid. And, you know, you could go down the line of all the type of GI drugs that we could give to them. Now, sometimes, no matter what we do, we cannot control their vomiting. And they're losing so much nutrition, they are having issues with growth, development, cognition, because they're vomiting all the time. So we're going to do something called a Nissen fundoplication. Now, in the adult world, if we put in a gastrostomy tube, they do a Nissen fundoplication. Why? It prevents vomiting because you fill them up with fluid at one time, they could vomit it up. So it's like putting a kink in the stomach as it goes up the esophagus so they can't reflux, because reflux will burn that esophagus out, right? Now, sometimes older children, they have reflux, you know, and what you will see is you'll see them coughing. That's almost because they're trying to aspirate, right? When something comes up your esophagus, it tries to get into your trachea, and you cough. Or sometimes they're complaining of heartburn all the time. So that's your older kid, how you could diagnose them with GERD. Infants, you can see it better, but if medically can't take care of it, the Nissen fundoplication is the treatment for chronic, you can't take care of no matter what, gastroesophageal reflux, okay? And we also do that for G-tube insertion, gastrostomy tubes, to prevent it going back up the esophagus and prevention of aspiration pneumonias. Now, this is a condition specific, it's vomiting. This is your infant up to maybe 2 months old. And this is a condition where I get a little infant admitted, comes into the ER, and mom says they're vomiting all the time. And I'm going to ask this one question. Is it vomiting dribbling here, or is it across the room projectile? If they say forceful across the room projectile, then I'm going to take my little hand and put it underneath the abdomen, right underneath the xiphoid process, and I will feel like an olive-sized little mass, like a little marble there. And that is the sphincter. The pyloric sphincter is all thickened, so you can feel it in these infants. So what do? These children, the food's not going through the pyloric sphincter and can't get down into the body. So again, they're not getting nutrition. These kids are angry, they're hungry, and they're vomiting everything. I'm talking 20 feet away, you could get splattered with these kids' vomit. That's how forceful this vomiting is. So number one, tell them, do not feed them anymore. You're going to start an IV on these children, and they do an ultrasound just to diagnose it, but these kids will go to surgery. And when they go to surgery, all they do is open up that sphincter, and they don't have any repercussions from this. We just open the sphincter. There's no follow-up with it. It's not like they have to every year go to GI and get it checked. It was just a narrow, so they opened up. It's stenosis, it's a narrowing. So pyloric stenosis is forceful projectile vomiting. Treatment, NPO, start IV fluids, and then the next day after surgery, they'll start clear liquid slowly to see if they drink, and then they're sent home. Another condition, mouth. You have to eat, right? You can't eat if you have, your lip isn't all the way closed or your palate isn't closed. You can't, if you don't have all of that there, you can't suck. So these children, it could be one side, two sides, it could be one side palate, two sides palate, no palate, and there's different things we do. Well, number one, what do kids do to comfort themselves? They suck, right? They're pacifier, they suck. They can't keep it in there. So what they do initially is they just will feed them with a special bottle, which I'll show you in a second. But they try to close the lips within the first 2 to 3 months. At least they can put their mouth around something, okay? Which helps them. Then they put this Logan bar, that's called a Logan bar, to protect that lip so they can't smush it into the bed and rip open those stitches, because these are plastic closures. They have to make sure that the lip is approximated really good so it doesn't look like a crooked lip. So that's all the things you can have. So then they go through and they're going to do the palate, the upper part. Now, if you can imagine, you don't have a palate, and I've seen it on one kid I took care of. He had the lips, but didn't have a palate. Feeding him, he'd have milk coming out his nose. You don't have the upper roof of your mouth, right? It can come up out of your nose. The problem with the palate, you need to have your palate to pronunciate words. So if we don't correct it, they're going to have a profound speech impairment. So we try to fix it as soon as we can. Now, you see that cute little bottle there? It's called a Heberman bottle, and that top is soft, and the nipple is soft. And when you turn the bottle over, the milk goes in the top. And slowly, when they're sucking or appear to suck, you squeeze a little bit and squeeze a little bit. And this child is going to have that satisfaction of sucking, which is what they need. The woman who wants to breastfeed a child with a cleft must be patient, because they literally have to squeeze as this child's trying to suck, and they can tire out. So we have to worry about not getting enough food, and then of course growth failure. And then the last thing is what we call some sort of absence or opening or connection between the esophagus and trachea that shouldn't be there. The first thing is esophageal atresia. Atresia without, that means the esophagus doesn't attach to the stomach. Where's the food go? It goes down and comes right back out because there's no place for it. So the other thing, and it's usually you'll see the combination, believe it or not, of both. It's called a tracheoesophageal fistula, or a TEF. And it's a little tube that connects the esophagus and the trachea. So if you eat, it goes down the esophagus and goes in the trachea into the lungs. Treatment, NPO. Do not feed this kid. It's going to go directly in the lungs, or if it goes down the esophagus and there is no stomach connected, you can aspirate, aspirate, aspirate. In fact, these children preoperatively, you must get them on an IV for fluids, and you need to give antibiotics because they're aspirating fluids, because your mouth is full of fluids all the time, right? It's always producing mucus. So they're always swallowing this mucus. You know, when they're born, they're coughing and they're bubbling at the mouth, you know, and you're going to see that that coughing like they're choking, and that it's showing you something is wrong with it. So maintain that airway by nothing to eat or drink. Have the head of the bed elevated, okay, which does help them. They do repair these kids. These kids are normal in every other way. It's just that the connections is not right, okay? So preoperatively, IV fluids, antibiotics, because they're aspirating, prevent infections. These parents can hold these children, not a problem. And just hold their head up. And of course, you'll always have suction at these kids' bedside. So NPO, antibiotics, elevate the head of bed, and have suction there available for these children. So is that enough good stuff for you today? A lot of interesting things there. So who wants to win the cahoots for today? Andres, are you ready for this one? Chelsea? Maybe? Sarah, you got this. I know you do. All right, Casey, you look like you want it too. All right, let's go ahead. Let's do our cahoots. All right, let's get going. Week 8, GI, GU. I'll multi-select. All the following are symptoms of dehydration in an infant.
Professor, I can log in. Hold me 1 second, please.
Okay.
I don't see the pin. Could you give me the pin?
244966. So when you talk about dehydration and you talk about infant children, you'll have that dry, that pale skin that I showed you. They're going to be weak and tired, lethargic, and of course the loss of elasticity. What are other things? Not crying with tears, no tears, prolong your capillary refill, elevated heart rate, decreased blood pressure, poor urinary output. All of these things are dehydration.
It's so good.
All right, here we go.
Professor,
What
for
is
some reason I
priority
can see it.
treatment for a child with dehydration due to profuse vomiting? So you have a child who's dehydrated. What do you want to do? They're vomiting. Okay, because they're vomiting and they're profuse, which means it's a lot. That means you cannot feed them anything by mouth because they're just going to vomit. This one's going to get IV fluids. Maureen, did you need something?
Yes, on my end, it says you're started sharing your screen and it's still like loading. I'm not seeing anything.
Okay, what about you? Anybody else?
I can see the screen.
Okay, well then, Maureen, just listen to it and I will send you the Kahoots too, okay?
Okay, thank you, Professor.
No, sorry. I wish you did. What is a treatment for an infant with diarrhea lasting for 4 days? Diarrhea.
Professor, could you tell me the pin again?
244966. So diarrhea does not need to have IV fluids unless they're severely dehydrated. This question, I know it's a trick question, but diarrhea, usually we give them PO fluids and we feed them. Usually we'll give them some sort of lactobacillus probiotic for their gut. And that's the treatment for diarrhea, unless the kid is, lethargic. And then of course we'd start an IV. But most of the time, we're just gonna give these kids something to eat. And that's going to be the Pedialyte, Powerade, Gatorade. What acid-base imbalance may you see with a child that's having profuse diarrhea? As I said, you're going to see about 4 questions on, your acid base, whether it's diarrhea, whether it's vomiting, something about your diabetes. You're going to see them on your HESI. And I know you'll have them on NCLEX. So I'm going to be testing you with them. Now, when you're having diarrhea, because of all of the enzymes that help with digestion, they are all metabolic, and that's gone. You lose them. So if all the they're alkalotic, and if all of that alkalotic material is gone, you're left with acid. So your answer is metabolic acidosis. Okay, it is not alkalosis. That would be vomiting because you're losing acid as you vomit. Diarrhea is you're having acidosis. Okay. A multi-select. An infant's not past meconium stool within the first 24 to 36 hours. What would you assess for? Okay, no meconium stool. You could have hypothyroidism, cystic fibrosis, Hirschsprung's disease. These are some of the things that we find out at birth that we didn't even know that the child might have thyroid issues or cystic fibrosis. There was no history of it. And Hirschsprung's, we know that there's no ganglion there. There's no nerve, so the stool's not moving. Electrolyte imbalance has nothing to do with stool passage at all. Deficiency of vitamin D causes what? And you talk about vitamin D and what is vitamin D good for, and it's good for bones. And knowing that will bring you right to rickets, okay? A multi-select. What treatment can the nurse anticipate to a child unable to drink or eat anything with profuse vomiting and diarrhea? So we need to know what that basic metabolic profile is. We are not giving them anything by mouth. Profuse vomiting. We're not going to do anything by mouth, but we want to see electrolytes and we're going to give IV fluids. Those are the two things. I'll multi-select. What nursing management would you anticipate for a child with a ruptured appendix postoperatively? Remember that appendix burst and the pain is gone, and all of that contents has spewed into the peritoneum, creating a lot of discomfort postoperatively. So we're going to put IV antibiotics because they have peritonitis. Going to have NG tube suction to keep that GI tract empty because it's angry. All of that, contents has gone into those intestines and they're red, raw, and angry. And because we don't know how good the tissue was that we closed up postoperatively, we're going to check that surgical site. Are we going to keep a post-op patient on complete bed rest? No. Out of bed, ambulating is tolerated. And of course, giving pain medicines to make sure they get out of bed. Passage of urine, usually at night in children who should have voluntary bladder control. And it's called enuresis. Now there's two names here I didn't go over, and I'm going to slowly go over them right now. Epispadias and hypospadias. Epispadias is a male where the penis, the hole doesn't come out the end, the urethra don't come out the end of the tip of the penis, it's on the top. It doesn't come out the end. Hypospadias is underneath the hole, not at the end. So usually about 6 to 12 months, they're going to take the foreskin, so they cannot be circumcised, and use it as a plastic sort of coverage over the hole. And then they're going to put a tube inside the urethra to hold it open. And they'll send them home with that tube in there. And that tube just sits there. It's just to hold open the patency of the urethra. And you go back to the doctor in a week and they take it out for you. And then the urine will come out the tip of the penis the way it should. You see this a lot in DeGeorge patients where it happens like that. And it's usually, I've seen hypospadias more than I've seen epispadias. So that's the one, they can't be circumcised and they have to have a surgical repair. They do it a plastic type thing. What is Hirschsprung's disease? Well, we know this one's going to need a colostomy in the end, which is temporary, usually for up to a year old. And it's called a congenital absence of the parasympathetic ganglion cells. Boy, look at all those words. Basically, it says there's no nerve cells in the area of the lower bowel, the descending colon. And then at the end of that is a tiny little opening that goes to the anus. Sometimes a little bit of content squirts out in little ribbons, but that's about the only sort of stool that you will see on these children, okay? So Hirschsprung's, you have to cut out that piece, do a colostomy, and then connect it within the next year. But the only symptoms is no stool or little tiny little ribbon stools. What type of stools would an infant with Hirschsprung's disease have? And these are the ones with the ribbon-shaped stools, yes, or nothing at all. What is the condition that occurs mainly in children when the intestines telescope into itself? And it's called intussusception. Usually they come out by themselves. We send them home on a high fiber diet, and rarely, but it sometimes happens, they need to have surgery, but it's called intussusception. Gastroesophageal reflux disease, GERD, what is that? So it's when the stomach goes up and it goes into the esophagus and it burns. It hurts. You'll actually see children, they'll bend and arch their back when they're refluxing. You're like, oh, this infant is refluxing. After you become a nurse and you see that working with infants, it's very, very obvious. Inflammatory bowel disease, IBS, involves what? And it's any part of the intestines, mouth to anus, any part of it. What would the nurse be looking for when the patient has Meckel diverticulum? And that's painless rectal bleeding, not a bleeding, but bleeding. That's funny. And it's a surgical, they need to go and remove that diverticulum because it's a blood vessel that just rips and just pours blood into the intestines. A 6-year-old goes to the ER due to abdominal pain, fever, vomiting for the last day. What assessment is priority? What are you going to ask first? What's your assessment? What do you need to know? You want to know where that pain is. Is it right lower quadrant? Is it umbilical? Where is it? You need to know where it's at to know what priority that child is. What would the nurse expect to see in an infant with biliary atresia? So atresia without biliary, that means that there's no connection between the common bile duct and the liver. So you're going to see stools that don't have bile in them. So they'll be clay colored and your abdomen is going to be distended. Those are things you would see. Of course, the yellowness of the child and the sclera, yes. And they need to go in and open up that duct so the bile can be going into the intestines for secretion and digestion of your fat, because that's what bile does. And if not, all this bile is going to go into the system. And we need to take care of that as soon as possible, surgery. What structure of the mouth can be impacted by a cleft lip and palate? Everything. It's the lip and it's the gum. Sometimes it goes into, and it goes into the hard palate, soft palate. The soft palate is in the back of the throat, and I've seen the whole thing affected. Cleft lip repair is typically done when? And there's that bottle working, as you can see it. And those 2 fingers there underneath are just squeezing it slowly for that child just to suck very lightly. So it's somewhere between 2 to 3 months. We try to get it done as soon as we possibly can, because we know children explore the world in their mouth. And how do they comfort? By sucking. So we want to be able for them to at least to try to suck. And that lip does help. When does cleft palate repair typically occur? And that's somewhere between 6 to 12 months. Because again, if we don't get that palate repaired, it's going to affect their speech. And it's also, again, with the comforting and sucking that ability. So we try to get it done as soon as possible. Esophageal atresia, what's that? And that's the lack of the opening of the esophagus. It can't connect to the stomach. It's just not there. So again, all that liquid comes back up. Chance of aspiration is great. So this child is made NPO until we can fix it. What are the classic signs of esophageal atresia and tracheoesophageal fistula? So you're going to see them turning blue because they're choking and they're aspirating and coughing. Now, this olive-shaped mass in that upper quadrant, that is pyloric stenosis. And the current jelly stools, that is intussusception. Those are some telltale signs. Kids screaming, abdominal pain, you open up their diaper and you're going to see like a bloody current, like jelly looking stool in there. So you know what it is. Multi-select. A neonate with suspected tracheoesophageal fistula, nursing care should include what? You have a connection between the trachea and the esophagus with a fistula, a tube. We're going to elevate the head of the bed. They're going to be nothing to eat or drink, because if they drink or eat, it goes down the esophagus right over to the trachea, and now you have aspiration pneumonia. So no feeding. And this kid's going to get IV fluids and antibiotics, because no matter how hard you try, they're going to aspirate. So we want to prevent aspiration pneumonias, prevent infections. A 5-year-old child with epigastric pain and a persistent cough, what would you suspect? And we're going to suspect GERD, reflux, gastroesophageal reflux, because they're aspirating. It's that cough. And when you feel food going up that esophagus, it burns and it hurts. Signs and symptoms of a hypertrophic pyloric stenosis. A pyloric stenosis, you'll see that little olive mass, the midline a little bit to the right, and that is the pyloric sphincter, and it's all muscular and it's thickened. So that's why you feel that. The other thing, projectile vomiting. Signs and symptoms of a hypertrophic pyloric stenosis. Projectile vomiting, okay? Poor appetite? No, these kids eat. They're hungry. They eat, cry, vomit, want some more because they're now not full again. Preoperative treatment of pyloric stenosis includes so this child, you make NPO, you start IV fluids, nothing by mouth, okay? And you're not ever gonna just leave an infant, which is up to like 2 months old, without it, and just NPO. So fluids and NPO. What does a celiac disease affect? When you think about celiac disease, you think about nutrition. When you think about nutrition, you always think about the small intestines. The small intestines is where you absorb all of your food and your nutrients, okay? And that's how you should remember it. If you have celiac disease, what should you eliminate from your diet? Wheat, rye, and barley. They can have rice. They can have dairy, milk, cheese, bacon, meats, all that's fine, but they can't have any of the breading sort of stuff. And if they do eat it, they get a lot of pain. I'll multi-select. Vitamins that children with celiac disease are prone to lose are and remember, fat soluble vitamins is what they lose. Vitamin C is a water soluble. So A, D, K are some of the fat solubles, which means these children are going to need some supplements. What foods would you select for a child with celiac disease? So they can have eggs, they can have milk, they can have fruit. French toast is bread, no. Fish sticks is a breading, and macaroni, the noodles can't have. And then the garlic bread is bread, no, they can't. So bacon omelet, bacon and milk they can have. No chicken nuggets either. What is phimosis? I mentioned this when we talked about urinary tract infections and the male. And this is when the foreskin gets too tight and you can't pull it down no matter what you do. It's too tight. And again, these will lead up to more chance of urinary tract infections in the male. What is a hydrocele? And it's basically fluids around the testes. Usually children who have this have pain in their testicles, but also they might have an incontinence spell where they don't know about it. And what they do is they treat it with usually a couple shots of Rocephin, and that usually helps, or sometimes just one shot and some oral antibiotics. What is cryptorchidism? Cryptorchidism is when your testicles don't come all the way down into the scrotal sac and they're up inside the abdomen. That's why you'll see pediatricians checking for the testicles inside the scrotum of male infants. Now, how do we treat cryptorchidism and really find out, is it that? Well, number one, when we're examining this, we need to make sure the room is warm, because we know males in a cold room, their testicles shrink up. So you're not going to get a valid assessment. So put them in a warm room and then we could check it. And they usually try to get that out within the first year, because the testicles don't like a really warm environment, like inside the abdomen. They like to be outside. So if we leave them up there too long, it will end up, killing the scrotal, the testicles. So we try to get them down as soon as we can. You suspect an infant has cryptorchidism. How would you examine this infant? So again, warm has the testicles get swollen and big. You're going to see testicles in there or not, and that will make it a valid exam. So a warm room. A hypospadias is what? I told you earlier in this cahoots what it was. So a hypospadias is on the ventral side of the penis, okay? The dorsal side is the epispadias. Again, we're going to treat that by keeping them not circumcised. We're going to treat them before they go into potty training. And we're going to have, it's under general surgery. They'll take the foreskin, use it as a plastic closure. They're going to put like a tiny little catheter in there, send them home. We don't do anything to that catheter. It's just there to help keep the lumen open and the urine passing. A multi-select. How is the hypospadias corrected? So we are going to use the foreskin for ventral opening. This might be a problem for your Jewish faith people, right? Because they like to do the brisk right after birth. These children cannot be circumcised, so we can close it later. Then we put the stent in, and it is done under general anesthesia. It is not a locally type of anesthesia. This is surgery. It's something that is quite painful, and they do a lot of manipulation. So local is not, no, it would hurt. What is a bladder exstrophy? Remember I talked about gastroschisis, and then I talked about the other thing that can happen is the bladder, right? So there's like a midline closure, they say. It's like right up the mid of the abdomen where the stomach didn't close, and it's the midline closure defect. And of course, it happens during embryonic development. But the bladder is just, again, midline, and the bladder was left open. It's all connected, still holds urine, all of those things, but we need to get it inside. And they sort of pull the outside skin up, and when there's enough room, then they push it back in and close it. And the kids do really well with it, as long as we prevent infection. What are the clinical manifestations of nephrotic syndrome? Remember, it is not renal failure. It's all about the kidney saying, I don't like protein, let me get rid of it. You get rid of protein, you're losing it out of your blood, you're losing it, and you're creating the environment where the intracellular goes extracellular and you get swollen all over. And you get edematous. Children with nephrotic syndrome are often given what medications for fluid overload? So when you talk about intracellular, extracellular, you're trying to pull fluid back from the tissues, back into the vasculature. How do you do that? So if we put protein back into the vasculature, into the blood system, and we give furosemide Lasix, it's going to pull it out and flush it out. And that does help with fluid overload. And they usually use a high albumin, like 25% instead of 5%. And it works really well. What is used to treat nephrotic syndrome in children? And we use prednisone for these children, and that's why they're prone to infections. A child is admitted with acute glomerulonephritis. What recent illness could validate this finding? So sore throat, remember, glomerulonephritis, rheumatic fever is about strep throat, pharyngitis. That's going to show it to you. Has nothing to do with the urinary tract infection, nothing to do with an upper respiratory. It's all about strep throat, rheumatic fever, and glomerulonephritis. What is the priority nursing care of a child with nephrotic syndrome? Priority nursing care. This child is going to be on fluid restrictions, salt restrictions, because they're edematous, because all their proteins being lost, so they're swelling up. What we need to do is monitor fluid balance. How? Daily weights, intake output. So daily weights are priority nursing care. Why is erythropoietin used in chronic kidney failure? Because it makes red blood cells and can help decrease the amount of blood transfusion this child might need. Very good. A multi-select. Children with chronic kidney disease can have renal osteodystrophy. What can do this to this child? Osteodystrophy, what does that do? So you don't have enough vitamin D. This osteodystrophy goes on where your bones, bones have an issue. So you're going to see skeletal abnormalities, growth retardation, and parathyroid levels, calcium levels are high. So has to do with calcium and vitamin D and bones, and they're not growing the way they should. And you're going to see all these abnormalities. And that's with your chronic kidney disease because it doesn't know how to filter the electrolytes through your body. A diagnostic finding of acute glomerulonephritis may be what? And that's your positive ASO titer because that measures strep, positive anti-strep. Perfect, good job. It means you're thinking, I like that. Which complication of peritoneal dialysis is most important? Most important to avoid? And that's, you don't want to make the place where all of your work for your kidneys is being done is in the peritoneal sac. We don't want that to be inflamed and infected. If it's infected, you don't have a kidney. You don't have a kidney, you're gonna have all those toxins just accumulate in the body, which we don't. So monitoring for abdominal peritonitis is so important. How would we know? Well, redness, tenderness, fever, and change in the color of the fluid that comes out when we're doing peritoneal dialysis, okay? Report to the doctor immediately. Get that child on antibiotics like now. So which clinical assessment is most important to report with a child diagnosed with an acute kidney trauma? You know, this kid was playing tag in the backyard and he came around the corner and his left upper quadrant in his back hit the trailer hitch hard, had this huge, massive ecchymotic area. And that was kidney damage. Whenever you think of kidneys, think potassium. So yes, potassium elevated is an important sign because now you're showing the amount of trauma that kidney had done to it. I'll multi-select. What should the nurse anticipate for a child who just had a renal biopsy? Renal biopsies. We stuck it through the back of his needle through his back. We're going to monitor that dressing. We're going to have a pressure dressing there, monitor INO, measure, watch out for abdominal swelling and bed rest for 24 hours. Yes. What would you do if the fluid draining from a peritoneal dialysis changed color and is now cloudy? You're going to notify the provider and you're going to anticipate you're going to be given antibiotics like as quick as you can, right? And last question. What would the nurse provide to an infant that cannot eat normally? You have a kid who's, let's say he has a tracheoesophageal fistula, they can't eat. You know, infants still need to develop normally, and part of their normal growth and development, you know, these are things that need to be done. And we need to give them a pacifier because remember, self-soothing, right? That's what the kids do. And that will prepare them as they get to the point where they can eat. They've already, that sucking, they're already doing that. So a pacifier, normal growth and development, important. Number 3, you, Lamar, good job. And you were late getting in. Suzette, look at you. Number 1. Liz, good job, Liz. Number 4, K&M. Sign your attendance attestations, please. Make sure you get them done. Make sure you've checked your other ones to make sure that they're there. Any questions for anybody? Remember, send in your projects. I'll review them if you want me to. Send me a message so that I can give you feedback. If you want to increase your grades, I would be more than glad to do that for you, okay?
Professor, let me ask you something. When I finish my project, can I send you where? Through Canvas, through UD?
Just send it right through there. Attach
Okay.
it right
Okay.
there. It's not a problem.
Thank you.
Remember, no class next week. I'll be sending you a recording from a previous quarter, okay? So that you will have it. And I'll send you the PowerPoints and I will send you the Kahoots. If
And
you
so
want
no
to
Zoom next
attend
week?
another class, you may. Ask me and I will tell you and send you the links. If that's what you want, no problem. You can attend something or you can, monitor my older recording that I have for you, okay? Thank you, guys.
Thank you.
Have a good evening.
You
Eso fue lo
too.
que-
Here, say bye.
Bye,
Bye.
Sheila.
You're